I thought I should say a few words about Antony, how he became a PhD student of mine and how he's presenting now. He's a new face to, I believe, to all of you. About 2 years ago, Antony emailed me with a question about a paper of mine that I wrote when I was much younger, and a technical question on how he could apply the same techniques using a software that I have been working on for a couple of years now. And although I promised that I will give only technical responses, along the way, Antony was asking some questions regarding specification. I told him, look, you should discuss this with your supervisor. And Antony came back to me and he asked me, oh, do you want to become my supervisor because I'm in need of one? So eventually I agreed. So I am the external supervisor for Antony. Antony is based in New Zealand at Auckland Technical University. It is 4 o'clock for him in the morning now, 4:05, but he was kind enough to present in our series. And I'm very grateful for that. I can show off what I'm doing outside the university. So Antony is finishing his PhD. We are currently working on his final research chapter, and he will be presenting something from his PhD research. Antony, the floor is yours.
Oh, thank you, Gregory. That was a very detailed introduction. And thank you, Stavros, for organizing all this. Welcome, everyone. My topic is looking at the cost inefficiency at New Zealand district health boards. I've been working on this for the last 4 years, and finally I'm starting to see the light at the end of the tunnel, I must say. Now, even though the date I put on my screen is 7th of October, it is actually 8th of October here. So I'm in the future, if I might say that. So what I thought is that before we get into the details, I just sort of discuss or mention at least some key concepts, because when we talk about inefficiency, different things can come in people's mind. The economist way is different, accountant way is different. So we'll just set the scene, just clearing that concept, what we're going to talk about today. So 2 things we can say in terms of effectiveness, and we can also talk about cost efficiency, which is what we're talking about. When we talk about cost effectiveness, we are talking about something that relates to a financial statement. You have been given X amount of money, and as a hospital, you are required to do 10,000 hip replacement, for example. So as long as you get that 10,000 hip replacement surgery done within the money that's been given to you, you're effective. But when we talk about cost efficient, of course, you have to get that 10,000 hip replacement surgery, but are you doing it with the cost that is the minimum? Or what we talk about is a minimum cost frontier. So if you go over that minimum cost frontier, that means there is a certain amount of inefficiency that you're operating with. So the main motive of cost efficiency analysis, if I put in simple words, is to estimate that minimum cost frontier. And that will measure each hospital or organization performance against that cost frontier. Now, when we talk about cost efficiency in this paper, what we're talking about is it's an ability of a hospital or a healthcare provider to select various inputs that minimize the cost. That is what we're talking about cost efficiency, which is of course related to what we just discussed earlier on. And then we bring in a new idea in healthcare, or what we call inefficiency persistence. That means that, okay, we know if we establish that there is inefficiency, and if we have a time series data, if you observe a period of time, is there evidence to show that the inefficiency has been carrying on over a period of time, that a certain amount of inefficiency is going through time, which is of course a long-term issue that definitely need to be addressed. And if it is not addressed, then you can imagine how much money is wasted if this carries on for a longer period of time. And then bring in a concept, what we call an unobserved heterogeneity. Now, not to sound too technical or get lost in the words, it simply means that if we got hospital located at different places, they might have some characteristics that needs to be controlled. Some hospitals might be operating in a rural area, some might be in big cities, or some might be providing tertiary level hospital services. So that needs to be controlled. So you can't say that things are equal for all these hospitals. So that's a way to control that we sort of call what we call unobserved heterogeneity. And then finally, scale economies, which perhaps everybody knows. It's just we talk about in terms of proportions. So if we increase all our outputs, what a hospital produces, how much is the cost going to increase proportionally? So if we are armed with these four ideas, I think we are ready to go into the details. Now, finally, a cost efficiency, because we like to see things in percentages, if we want to calculate the cost efficiency, we say, okay, we know the efficient cost that comes from the efficiency frontier that we just seen in the previous slide, and it divide by the actual or the observed cost, and then we get a ratio, and then we know exactly what the cost efficiency rating for a particular hospital is. So what is this efficient cost? How do we estimate that? So economist has worked out that if you have a function that includes the input price, and which is denoted by W here, the price of the doctors and price of the equipment that goes into hospital production system, and the output, that is Y, outputs can be your inpatients, outpatients. If we have a function of that, and we can establish based on that a minimum cost frontier, that is, or in other words, the efficient cost frontier against which we'll be comparing each hospital's actual costs. Now, the method that I'm using here is what we call stochastic cost frontier or stochastic frontier analysis, which says that, okay, that's all well and good. Okay, you got this input prices and you got output that you estimate the cost function. But hey, look, there are certain things in the hospital that is beyond the control of management. So you can't blame the management for that if the cost goes up, because there might be factors such as random equipment failure and the maybe staff is on strike. So in that case, hospital might have to hire somebody from outside and pay a higher cost to them. Well, then they are not efficient. So in that case, we say that, okay, there are certain things the management can't control. So we do need to account for that to be fair to them. So that's why we add this variable called VIT to the actual efficient frontier. Finally, then we say that, okay, well, we accounted for that. What about the actual inefficiency? So that's what we call a stochastic cost frontier. So we have our actual, then we have our the disturbance to the system, the things that I just mentioned, and then we have inefficiency. So that's our whole idea, to get the observed data and construct this function. How do we separate this random shocks to the system and also the inefficiency? What we do in econometrics is that we impose some assumption, distributional assumption, purely just to differentiate between each other, because otherwise we don't know how to differentiate. So we say, okay, we have an imposition of a distribution here. We have different type of distribution we can impose here so that we can just separate them. So that's what we do in basically generally in stochastic cost frontier. So I get into New Zealand health system now. What we have in New Zealand, just to give the audience a little bit of idea about what we famously call is a district health board. So different part of New Zealand have district health boards. Altogether, there are 20 district health boards in New Zealand, and they are solely responsible for providing the public hospital services in their geographically defined regions. Now, why I use the word solely is that there is no private hospitals that can actually provide you acute care or emergency care. You have to go to a public hospital to get that care. There are private hospitals here which mainly do what we call a planned surgery. You can't, if you get something wrong with your heart, emergency, you go to basically public hospital. So they have a very strong role, the district health boards. So district health board not only manage hospitals, they also provide the primary healthcare services, the mental healthcare services, the elderly care. So, but hospital is one of the most important function that they have, and that's where the most of the money that's given to the district health board goes to. They use what we call a population-based funding formula, where each region gets the money based on the mix of people, the demographics, socioeconomic situation of people living there, whether they're in a rural area, where they provide tertiary level hospital services. So all this get taken into account. It's very controversial because DHBs always complain they don't get enough, and but that is what they work with for last 20 years nearly, when this DHB was established. And then budget deficits. So as with public healthcare system, budget deficits is very difficult or much discussed issue in New Zealand. Now, budget deficit itself doesn't mean that the district health boards are actually operating with inefficiency, because of the fact that the money that they're getting might simply not be enough. But it does provide some motivation to look into, inefficiency and sort of quantify them and see what's actually happening. So this is the list of district health boards, just briefly. So you can see it's sort of very different in terms of the area that they cover, urban and rural, and the type of hospital service they provide, and also the population. So where I'm based in Auckland is where the most population is, and that's where the big tertiary hospitals or specialist hospitals are located. And so the idea about this table is that it needs to be, they are very heterogeneous. So we do need to account for these differences between these district health boards. So it's very, very important. And we can see in the slides that are coming up that if you don't do that, what happens. So previous studies on New Zealand District Health Board, what has been done so far in terms of inefficiency? There's about 4 papers so far. And they use, all those 4 people do use what we call a data envelopment analysis, which is a non-parametric method, which is not what I'm using. In simple words, it's more a mathematical, why I say mathematical is, obviously the method I'm using is also got math, but this is purely mathematics in terms of we don't have a distributional assumptions like we make in statistics. And there is no ability to actually account for unobserved heterogeneity very easily in this data envelope. So these studies just basically ignore that these district health boards are very different. And that's what the last paper does use stochastic frontier modeling, but they did not control for DHB level heterogeneity. Or most importantly, they also assumed that inefficiency independent. That means they didn't, they're sort of saying that, okay, well, there is no inefficiency persistence in the system at all. So this paper that I'm doing of my thesis is basically just to take that study a step further and see him. Once we control that and once we allow inefficiency to persist over a period of time, what we're going to see. So persistence in inefficiency. Now, it was a concept that was put forward by Sionas in 2006, and it was adjustment cost was used as a motivation for it. Basically, adjustment cost means that, okay, if there is we talk about a hospital, he didn't use hospital as an example, but in case of hospital, the doctors or the management of the hospitals have difficulty in adjusting to the inputs that minimizes the cost. There might be some barriers. It might be just regulatory barriers in terms of the way the system's set up. And so if there is some barriers for my hospital to operate efficiently, then what I might do is, I can't control it. So what I will do is that I will partly remain inefficient for a period of time. So that will cause our inefficiency to persist over time because of the huge adjustment cost that I have. If I want to bring my hospital up to a level where I can quickly adjust, I might have the inefficiency that is follows through time, and that means that I will have a long run equilibrium of efficiency instead. So if you think about out of 0 to 100, 100% is fully efficient, we are saying that, okay, a hospital will never achieve 100% because of the fact that there is adjustment cost, which will in turn cause inefficiency to persist. So we need to account for that. We need to keep that in mind that, okay, there might be significant adjustment costs. Let's think about that and let's put that in the model and see how we track it. So when we put all that in the system, we're saying that, okay, there is a dynamic system, dynamic in terms of it all goes through over time, where inefficiency will not or very slow to disappear over time. That is, they persist, as linking it back to my earlier points. So we must distinguish between what we call a short run. Short run will be what is hospital able to do in their day-to-day management and how they're able to control the costs to reach some level of efficiency, and long run means where there is persistence, where there is a lot of adjustment costs. So these two needs to be distinguished, and that's the contribution of my paper, basically. So what is the motivation for persistence, particularly in New Zealand district health boards? Why did I go into all this pain of putting that all in the system here and do this analysis? So the couple of reports that have been put forward, one of them where the controller and auditor general say that the equipment that is in district health boards is way too old. It's past its useful time, and it's one of the reason that significant inefficiency exists. Everybody know there is inefficiency in the district health board, but there has no study been done prior. And you notice that the studies that I mentioned was just done a couple of years ago, just since I started my PhD. And then there was a report by Treasury saying that if they want to get the level of infrastructure up to the level that is required for a well-performing health system, they have to invest approximately about 222 million for next 10 years. So you can imagine how old the infrastructure is. And then a couple of few regulatory disincentive as well that I like to mention. Bulk funding. Now, why is district health board not investing in these important equipments or the infrastructure that we need? It appears that the population-based funding doesn't distinguish between the capital funding or the operational funding. They get this bulk of money and they say, okay, well, you're your own and you have to run your hospital based on the money. So hospitals doesn't really have any incentive to invest in capital. And one of the reasons for that is what we call a capital charge payment. Now, capital charge, I think, is a concept that is well prevalent in UK, or at least that was, taken from there. So that means that the hospitals or district health board have to pay a charge or a rate to the government for the Crown's investment, basically, into the health system. And there have been several reports after reports saying that this capital charge actually does disincentivize JHB. So if they invest more, obviously they have to pay more capital charge. So the capital charge system has been called for a long time by different organizations to be scrapped because it's just putting things on the back burner, basically. But at the same time, if you scrap them, then how is that price or the cost going to be accounted to the taxpayer? So it's a bit of a difficult situation, but that is known to be one of the leading causes for district health boards for not to invest in the capital. And the third thing that I think is what we call a hospital target. This was about 10 years ago when the centre-right government came into New Zealand Parliament. They established what they call an hospital target. So that means hospital target is simply very short-term targets that if a particular patient presents itself to a hospital, within 3 hours, they need to be looked into, treated, or, transferred to the next department. So it was a very, very short-sighted targets. Now, why I'm putting in that there is that because there are study done, especially by the Treasury, they said that, okay, this hospital targets that we're talking about is forcing DHBs to look into short-term gains. So once again, they're taking the money out of what should be going investment towards these meeting the short term. So that means that hiring more staff, because they are monitored on these targets every 3 months. So you can imagine, if they don't meet the targets, they're going to hire all these people, because if they don't meet the target, they don't get the money basically. So once again, the money that should be going to the capital investment to improve the infrastructure, once again get piped into hospital targets. So I think these three briefly, I think, are one of the things that actually can be a reason for persistence and inefficiency, because simply the capital or infrastructure is so bad that just there's no way they can actually improve efficiency over time. So now I'm just going to get in a bit more technical, or the economics. If I simply talk about a hospital's production process, a district health board's production process, I'm going to say that, okay, there's some inputs that go into a system and it produces an output, or what we call a hospital service. I know a very simple idea, but will make it more apparent as we go through the slides. So we have different inputs that goes into hospital production system. We have labor inputs, doctors, nurses, everybody else who provides the human services. And then we have capital inputs like all your buildings and your equipments. Then you have clinical supplies, medicines, and all other consumables. And then you have outsourced costs. So that's interesting. So outsourced costs includes the labor. So when hospital is particularly busy and the staff that is permanently employed is not enough, district health boards often rely on outsourced personnel. So they hire private nurses to come in and fill in the gap that's there to meet the demand. And then also a part of outsourced cost is the hospitals often outsource certain services. For example, a CT scan, maybe an appendix operation that might be in a private system, they might just outsource, they pay for it. So all that put together is what we call labor, and also the service cost put together. So if we briefly say there are 4 inputs that goes into the production system, and the output that we get is the inpatients and outpatients. Now I know that inpatient, outpatient might not be exact, because obviously if you want to talk about inefficiency, it will be very, very good to account for the gain in life expectancy, for example. Those sort of things, but we don't really have data, and it's very difficult to argue that hospital is just one of the factors that actually improves the the life expectancy, because there's a lot of factors that comes in there. So it's very difficult, and obviously data will have a lagged effect. It might take time to have an effect, and we can't really compare quarter to quarter or year to year. So that's why we resort to what we call inpatient, outpatient. So we're saying this much inputs goes in the system, this is the outputs that we get. So a cost function requires input price. If you remember my first couple of slides, we talk about that function. So we need to know what the input prices are. Then we can say that, okay, if given these input prices, are the district health boards using the minimum input prices to provide that service? So we need to know the input prices. So that's what the data is. So I got quarterly data for 20 district health boards from the period 2011 to 18. That gives about 640 observations. Now, one of the important things I want to highlight here is that each DHBs might have more than one hospital, but we don't really have data on hospital level. They don't collect that data in hospital level. So the data that we have is aggregated data. So if a district health board has more than one hospital, that's all put together. And this is how we estimate the labor price. So we have a medical staff price. We simply take the total cost that a DHB or district health board incur every quarter, divide by the number of FTE that they use. So it gives you the price per FTE. So we have a medical staff price, which includes the physicians and the surgeons. And then we combine all other staff, which is your nurses, your allied staff, your management staff. Now, why do we combine that? It just reduces the amount of variables that we have in our system. Now, but we can't just combine them together because the prices might be different. So what we did is that we weigh them based on their share of total labor expenditures. So that really accounts for one that is expensive will get the more weight. And then we got capital and other input price. So capital price is estimated by the sum of depreciation and a capital charge rate. As I talked about capital charge earlier on, we sum them up to get the price. We get a percentage price. Outsourced priced, we are combining the healthcare wage index to account for the people who get hired from outside, and also healthcare provider index for the services that get outsourced. Once again, that's also weighted by the price. Clinical supplies price is approximately by a pharmaceutical products index that is available in the website of Statistics New Zealand. And the outputs is something that I will explain a little bit more detail. So we're using what we call a case-weighted inpatients. That simply means that, okay, a patient that comes into a hospital and get admitted who has a heart surgery is not same as a patient that get admitted who has an appendicitis operation, because they simply use different types of resources and the length of stay in the hospital is different. So case weighted sort of assigns more cases basically to more complex procedures, or a patient or inpatient that get admitted that uses more resources. So that's a way to sort of assign more weight to the patients who use more resources. Similarly, the outpatient visits, the patients who don't get admitted, is price weighted. That means that we have a price for each particular department of outpatient. A outpatient that goes into an orthopedic department have a price. So we try to weigh them as well, and that is based on the price. Now, we don't do that. I mean, that's been done by the Ministry of Health, and we simply got the data from them. So, and hence our total expenditure is just the sum of all this labor costs, the depreciation called capital, all these costs combined. So we got a price as our independent variable, if I may say, and our dependent variable is the total cost, that all the costs that have been incurred by adding up all these inputs. Right, so now we're going to get into more mechanical stuff here. We're going to estimate the cost function. Now we're going to get into the real econometrics of it. What we are using is what we call a translog cost function. I won't go into too much detail of that because it's technical, and our intention is not to be technically proficient here, I guess. It's a very flexible function that actually accounts for inputs and outputs that goes into the hospital production system in a very flexible way. What I mean by flexible way is that it allows interaction in a hospital where there is different proportion of nurses and doctors and different different outputs come together. So it allows for all different interaction and is a very flexible form. In other words, simple words, this probably reflect reality more than a simple, for example, Cobb-Douglas production function. I must be careful saying all this reality and stuff, but that's a simple way to understand these. Now, we also impose what we call a linear homogeneity, which is simple, that it allows us to just interpret everything in terms of proportion. And we do that by dividing the input price and the total cost by one of the inputs. It's just a fancy way of imposing that. And then we have all this variable that we specify that actually talks about that captures unobserved heterogeneity, which I name as random disturbance here. And we have a variable for short-run cost inefficiency, and we sorry, I just got mixed up here. So random disturbance is what we're talking about, the disturbance that hospital can't control. And then we move on to what we call an unobserved heterogeneity that controls for a district-specific, situation that needs to be counted, basically. And we also add, because it's a quarterly data, it will be very important if we add a quarterly, because there's a lot of our seasonality in wintertime where hospitals are very busy compared to summertime when they are not so busy. So it's very important we account for that. And now this next couple of slides is very, very, what was the word I'm using, is quite full on. It's quite cluttered, but I do apologize for that, but we don't need to go through it. It's just setting up our system here. We set up all our nuts and bolts of the system. And I must pass that this model that I'm using is one that's been invented by Gregory. So I must say that I should never forget that. And we impose all the structure. The important thing is that the structure by structure, the most important thing we do here is that we allow inefficiencies to persist. And how much of that is persist, we sort of restrict that in terms of 0 to 1. So close to 1 means a big amount of inefficiency is persisting over a period of time, and close to 0 means that there's no persistence. So that's basically what we're trying to do, to impose an autoregressive structure on it. And rest of all is all more mechanical stuff here. And once we impose all this, we can get an estimate of long-run cost efficiency, which is when there is persistence, we can't achieve 100% efficiency. So that's where we talk about long-run expected cost efficiency. And then we can also have a short-run cost efficiency. So we can make a comparison. Okay, if they can't achieve 100%, and then they can only achieve 90, well, that's fine, because the way a system is set up is that they can't go to 1, they can only achieve 90. How are the hospitals or the district health board, targeting against this 90? Closer to 90 mean, okay, they're doing very well. There's nothing much they could do. The regulation is to change so that they can actually go to 1. But that's the whole idea, distinguishing between your long run and the short run. What are we estimating? How are we estimating? We're using some Bayesian methods to estimate those, and this is all the technicality around that. But we don't need to go through that. We specify some priors in terms of that. What do we know about it? Here we say that, okay, well, we just want data to speak. So we say that we're not imposing any strong priors in them. We're not telling that this is what we think is it. We just leaving it open to data. We say let be the data and let data tell us what that is. So that's basically what we're doing here. When we talk about priors, there's no strong priors that we're imposing on our parameters. And we use Markov chain Monte Carlo to derive a posterior distribution of posterior moments. Right. So now at last we're ready to see some results. So there is 2 set of results that I'm producing here. The first is the DSF result. So DSF result is where I am not controlling for unobserved heterogeneity at all. I'm not saying that the district health boards are operating a different area. They're any different. In simple terms, that's what I'm saying. They all are similar. But then I'm sort of having another column here labeled DSF RE. RE means random effects, or I'm controlling for unobserved heterogeneity. I just simply want to do that. Just want to demonstrate that if we don't control for these area-specific characteristics for these hospitals, then we are severely going to bias our estimate, which is something that we will be very careful when we do the inefficiency analysis, because you're not even close of comparing apples to apples. So we do need to do some sort of adjustment to make sure that we have reasonable comparison. So you look into your economies of scale. You're looking at 0.99 when we look into the model that is not controlled for heterogeneity. That means basically if you increase your inpatient outpatient by 100%, your cost is going to increase by 99%, so very close 1-to-1 ratio. On the other hand, when I control for the unobserved heterogeneity, you will see that, okay, well, that's not actually true. It's not 1-to-1 ratio. It's actually a 1% rise in inpatient only increases costs by 0.24%. So there is a lot of economies of scale to begin, which is expected in a hospital, because hospital does operate with a lot of excess capacity. I mean, last thing you want is going in the hospital and saying there's no capacity, right? So which is more close to a reality. And we also find, this is very unusual, we don't find any evidence of technological progress. And basically what we're saying, in 2011 to 2018, there has been no technological progress in the health system. Now, persistent parameter, this is the parameter that actually controls for how much of the inefficiency get carried on from one period to next. Now, the bias estimate or bias model actually says 98.78%, which is very, very high. But when we control for unobserved heterogeneity, it drops down to more reasonable. We're looking at somewhere around 92%. And you can also see the difference between the short run and the long run. In the bias model, it severely underestimates the efficiency. It just goes to 68. of short run and 69% for long run, but we control for that to get more reasonable estimates, saying that, okay, well, there's a 92% in a efficiency rating for short run and 93 for long run. So you can clearly see if you don't control for this, which is a very simple thing, you should control it, but in studies often it's not done. If you don't do, severely biases your estimate. Now, finally, to look at because this is just a plot, just to say clearly the plot that, okay, we have a long run cost efficiency, which you can see is a straight line because, that doesn't change because of the persistence. And the short run is how the hospital perform against that. So you'll notice that most of these health boards here are, the short run is sort of going around close to those long run, because that's sort of where they operate in a long run, close to that red line, which is a long run equilibrium level of cost efficiency. And you notice particularly these two district health boards, they consistently operate below their long run cost efficiency. So that clearly means that there's something wrong with the management system that they need to look into what's going on. Because long run, we can say, okay, that's beyond your control, but short run means that, okay, you need to do something about that. What is the reason for that? So these two particular DHBs also happen to be operating in rural areas, which we'll get into that next. So this is sort of a estimate of based on the lowest performing to the highest performing. And so this is where I need help with an assistant in terms of, so I won't say some recommendation, I'm just use the word some observations here, because what I like from the audience is some idea about what's the reason for this, this what we see in terms of rural district health boards, and what can we offer, what can some of the policy we can actually come up with. So overall, it appears that the district health board that operate in rural areas appear to have a high level of long run cost inefficiency. That means the persistence is causing them to have a very high level of long run cost of inefficiency. So I think perhaps we can say that, the communication technology, because rural area, they provide service some of the remotest part of the country. Perhaps, the transport cost is one of the costs I know the rural district health board always talk about. Getting the patients to get a surgery, then they have to pay for transport. That's one of the issues. Even in outpatient, they have to drive the patients to come to the nearest hospital. That is a cause of higher costs for them. Staff shortage is also very difficult to get the staff to this rural area. So they frequently hire these people from outside that obviously very high cost. And other thing we see, there's no technological progress, as we mentioned, but it might be due to that the quality has improved, but we have no way to incorporate the quality in our system at the moment. So it might be that the quality is improved. That's why you notice that there is no technological progress, because technological progress basically means your cost will fall over time. But cost will not fall if there is improving the quality. That means you're spending more money, but your quality is significantly greater. So we haven't accounted for quality, so that might be the cause. That is something we can look into future. So existence of substantial, as we noted, there's a substantial scale economy. So I guess there is a lot of spare capacity and some better planning, especially for elective procedures, because there's a lot of delay to get an elective procedure. So maybe better planning will perhaps help in using some of those spare capacity. Also improve collaboration. So DHBs that are close to each other perhaps can have improved collaboration and share staff, and some of the patient perhaps that can actually utilize the spare capacity. And then these two DSB that I'm talking about, as we see in the graph here, they operate well below the equilibrium consistently. So they perhaps will look into the similar size DHBs and look into okay, what are we doing wrong? What can we learn from them? Perhaps that can help them to improve their short-run inefficiency. So these are some of the observations that I found, but obviously I would like audience to, give some more ideas around these. So rural DHBs, their long-run level of cost efficiency is only 0.87. So out of 100%, 87. So they are basically restricted to 87%. Rest, what we're talking about that stops them to reach 1% is all because of regulatory system. That's something not they can control. It's too expensive for them to actually reach to that level. So that's particular for rural DHB. That's the main finding from this paper. And if you put some numbers around that, if you reduce that long run inefficiency by even 1%, that will be overall will be a savings of about 165 million based on what they spent in 2017 and 18 financial year. Overall, with this 0.87%, THB's overspent about 15% of this budget because of this, the adjustment costs that they have, the regulatory structure that they have. So that's, I think, what I have to present, and that is all the reference. So now it's the time for suggestions and questions, perhaps. So thank you.
Thank you very much, Antony, for the very, very interesting presentation.
Thank you.
I have to say, even though I'm coming from the DA, let's say, side, I really enjoyed your explanation through the technical stuff and very good policy implications. I really enjoyed your presentations. I have two questions in the chat. So I will first ask David if he wants to ask his question.
Sure.
Sure, yeah, very good topic, a really important topic actually, and one that kind of global significance as you sort of compare, say, the New Zealand health system with others. But I was just wondering whether you'd maybe liaised or touched base with an accounting staff member, because the notion of costs, you're coming at it from an economist's perspective, and often the accountants will have something to add. So, for example, we would have the notion of fixed costs and variable costs, splitting costs that way. Also, the notion you were talking about, kind of semi-permanence nature, or the sort of the inefficiency persistence. Some of that could be because the accountants are playing around and smoothing out the costs.
Right.
So the cost this period will inevitably be linked to next period because of that. So just wondering whether you might want to touch base with some accounting staff just to get their input as well, to give you a better understanding of the kind of nature of the things you're looking at, and coming at it from a different discipline and a different perspective.
Sure. So just understanding this, so some persistence in costs might be due to the accounting process. Is that what you're saying?
Yes, that's what I'm saying. Yeah.
Right.
In fact, the accountants build it in. We build in that with accruals and repayments of costs. We definitely smooth it out. We smooth it out with capital expenditure, which by definition is lumpy, and the accountant comes along and smooths that out then with depreciation or whatever. And then even revaluations and also capitalizations, moving stuff out of the income statement onto the balance sheet to smooth out your net figure. Now in the UK, there's still some cash accounting going on within the healthcare system, where actually you don't have that going on. But I don't know about New Zealand, where they've moved to an accruals basis, where you do get this smoothing going on. Also within accounting, as I say, some costs are fixed, some are variable, and we would split costs that way. And that might have implications for some of your modeling. So just a suggestion to maybe
That's a great suggestion, because often we economists just go into our own hole and just don't think about other things. So this is fantastic. Okay, so accrual. So in case of accrual cost, this will persist more. Is that what you're saying?
Well, you take a bit out of this year's cost and move it into next year because you argue it belongs to next year or 2 years' time. Or, for example, if you argue something relates to this year, a cost relates to this year, but you actually haven't paid it yet, actually you bring it back from next year into this year. So we play around with costs to smooth them out or to match, sometimes matching costs with revenue and things like that.
That very good point, because I sort of talked to a district health board and sort of asked them, hey, what is the reason all of a sudden your expense for this particular thing went up? And they came back to, they used some word with accounting adjustment. So very good point, because that might be the, yeah. Okay.
Have a chat. Now, some healthcare systems are still, some health boards are still on a cash basis and don't do that. So, but I don't know about New Zealand. And again, I'm not a qualified accountant. Some of my accounting colleagues would know more about this, but this is certainly an issue. Also, you're talking about the charge on capital. That's a big issue within accounting in terms of working out the true profit or the economic profit. So this notion of applying a charge to capital is something, but then we would maybe net it off against depreciation and things like that, rather than added. But again, these are just suggestions for you to follow up.
Oh, thank you. Very, very, very good suggestions.
No, really interesting.
Oh, thank you. So sorry, one last. So capital charge is still in UK. Does it still in hospitals? Is still?
I'm not 100% certain. I know the government brought it in universities.
Right.
There is a big literature about costs within the healthcare system and costs within hospitals. And again, Teresa and others might know more about that. And I've read 1 or 2 papers, but I haven't kept up to date with it.
Sure. Okay. Yeah.
There is a big literature on it in the UK.
Sure. Thank you.
Mohammed has a question.
Sure, Mohammed, go ahead.
Yes, hi, Anthony. Thank you for that presentation. It was very fascinating. Although it's outside my major, I found it very interesting. The question I have, excuse me for my ignorance on the topic, but in terms of, from an economic perspective, in terms of externalities, whether it's positive or negative externalities, things that are not financial or countable, how should those be considered? If so, how can they be considered? For example, the level of service they're receiving, the happiness of the customers, the success of the surgeries, such things.
Absolutely. Yes, that's a. It's not ignorant at all. It's in fact, it's a very smart question, because a lot of economists forget about these things sometimes because they get too absorbed in the technicality. Now, we thought about a couple of things. Me and Gregory did talk about, thought about a couple of things to account for the quality. So a person comes to a hospital, get a surgery done, but similar surgery in a hospital might be completely different experience. So we need to account for quality. A couple of variables we thought about a readmission rate. That means, okay, if a particular hospital got a very high readmission rate, that they get discharged, but within 7 days or within 20 days, they come back again when there is clearly something wrong about the quality. So we did think about that, and we do have some data on that. And also we have the regulatory authority that look at the quality, that monitors the quality of the hospital service in New Zealand, does have some variables that actually just see, okay, how many of the hospital have actually harmed the patients. For example, the fall in the in the hospital, elderly people especially going to hospital, not getting proper care, fall, and they have injuries within hospital. So those are variables are available, but so that's something next we do want to account for that, and we are just sort of looking at different ways we can actually do. We did try readmission rate, but it didn't really make much difference to our estimate. So I think that probably might not be the best the variable to account, but we just have to move on to the next approach, and that's something we are actually going to keep in mind. So that's a very, very good question, and that is something we do need to do that in future to get a complete picture, of course. So thank you for that question. It's a very good question.
Thank you for that answer.
No worries.
I also have another point, sorry, just quickly. When you were talking about the difference and some observations between the rural areas and the other areas, could it be that such areas are less supervised, less competitive, less demanded by maybe professionals or administrators, so they have lower standards?
Right. Okay. I know in terms of, so you're saying the rural hospitals don't really have, in terms of quality staff, is that what you're saying?
I mean, they might be just less, not even in terms of quality, just like someone supervising the costs and these things and where the money's going. And for example, I'd imagine a place like Auckland to be more demanded. So the person responsible would be more supervised and more worried about being effective and efficient in comparison to another area.
Right. Yeah, that's a very fair point. So what we know about the rural parts is they're constantly crying out for more money, particularly in rural areas, because what they say is that this big specialist hospital, like in Auckland, the big tertiary hospital, get a lot more funding than the rural hospital. They do get an extra funding in saying that, okay, they do recognize that there are people living there that are far away, so but they do indicate that they do get less money. But I don't know whether that is the reason for their inefficiency, but it might be just because of that they just got more expense, I guess. And obviously, as you sort of notice that the technological investment is very, very poor. So I think investing in technology will be much beneficial for, especially in COVID time, we can see that what we can do in the virtual world. So perhaps having a doctor's appointment virtually will actually work better for them, reduce their costs, transportation costs, especially for outpatients where doctors doesn't necessarily need to, touch and I guess examine you. So so that's, I don't know if that answers or not, but yeah, that's sort of what I think about the rural. But I'm more open to hear more about it if we have time. I think 5 minutes.
David has another point to make, and if anyone else has a question, either put it in the chat or raise your hand. Yeah, David.
Yeah, it's a general point really about labeling things as inefficiency. So, for example, the last point there, possibly the rural inefficiency is because they have a lower throughput. And so therefore your cost per unit is going to be higher, but that also depends on whether bulk of the costs are fixed or whether they're variable. So the variable cost should be similar, but your fixed costs over a smaller number of patients will by definition be higher. And again, within accounting, within businesses, they look at things like throughput, costs per unit of scarce resource, things like that, to sort of look at things like that. So maybe chatting there would help as well.
Right. Makes sense. Yes. So they're basically different from the other you're talking. Yeah. There is. Yeah. Okay. Thank you.
Antony, I have a question. I have a specific question, and then I have something else that I would like to ask you. First of all, regarding when you were talking about your outputs, you mentioned the case-weighted one, and I was wondering whether the weights for this are also determined by the ministry as the price-weighted that you mentioned earlier, or if you determine the weights with some other procedure.
Oh, so you're saying that whether they are consistent for all the health board? Is that what you're asking?
No, I'm asking how you determine the weights.
Oh, right. So it's a very standard practice all over the world in terms of determining this weight. We specifically use the weightage that is determined by the Australia and New Zealand health. They use what they call a diagnostic related group. So a patient comes in there. They have different codes. They put dot marks in there saying this patient had this issue. How long did they stay? And I don't really know the mechanical of it, but I know it's very consistent between Australia and New Zealand, and that's an internationally accepted way of how they weigh it.
Okay. Yeah, clear enough. So it's expert knowledge, let's say. Not determined by you. Thanks a lot for this. And I was wondering, well, Gregory knows these things way better than me. I was wondering whether you are following the conference in the area, the North American Productivity Workshop and the EWEPA. In the area of efficiency and productivity, whether you are planning to go to the conferences, our communities very welcoming, and I really think that you would be benefiting for coming to our conferences.
Sure. I mean, there was a plan this year, but I guess COVID came in and all the plans are. Yeah. But yes, that's definitely will be very good. Once.
Yeah, well, if things go well with COVID, we would be happy to have you with us in Porto.
Oh, I'll be very happy to come and meet everybody. Thanks.
Yeah, David, I guess we have a couple of minutes for a final point. David, I can see your hand up, or is this a residual hand? Okay,
sorry, that was a legacy issue, Stavros, sorry.
Yeah, okay, a final point from Osai. Do you want to come on the microphone?
Hi, Antony. I hope you guys can hear me.
Yes, I can hear you. Thank you. Yep.
Yeah. So my apologies if this is not in line with your study, but I know that in the operations management area, they've listed out operations performance objectives, and I realized we're talking about cost. Cost is one of the operations management objectives, as well as quality, speed, flexibility, and dependability.
Sure.
So just for, I was just wondering if it's going to be, you know, something you could think about, if you could just look at how costs, and in this case, the inefficiencies could probably have an effect on, someone else also talked about quality, but
right.
then you could also maybe see if it impinges on dependability, flexibility, any of the other performance objectives. It's just a thought anyway.
Right. Okay. So you're saying performance objective for different health boards might be different, and that needs to be accounted. Is that what you're saying?
Generally, for operations, these are the different objectives that are used to measure operations performance.
Sure.
So, for if different hospitals, for example, have different levels of performance, then it's likely that there will be different levels of the different objectives.
Sure. Okay.
Yeah,
okay.
So, I mean, it's just a thought.
No, very good thought. Thank you. Thank you.
Yeah, that was my suggestion. Thank you.
Thanks.
Okay, I guess it's 5 o'clock. So thank you very much, Antony. That was very, very interesting. Thanks again for waking up at so late at night for you, or early in the morning. Yeah, thank you very much.